many different conditions. They may be lesser than a cellulitis condition or something which is more advanced. So first we start with, I would like to put upon the panel this thing that how do you define cellulitis? Dr. Newman, what is your opinion?
Cellulitis is a type of non-purulent, non-necrotizing infection of the skin and subcutaneous tissue. It is usually caused by microorganisms like Plasmodium, Staphylococcus aureus, or group beta hemolytic organism.
Okay. Any other opinion from the panel? Dr. Narita, do you define cellulitis just as an infection or something more specific which defines what is cellulitis?
Sir, according to dermatology, we say that it is, as he's already said, that there is no purulent discharge, but
Okay.
this is definitely, cellulitis is definitely inflammation due to infection of the dermal tissue.
Dermal, so that this is the key point, you know, where up to what layer the infection has been there, and whether there is a component of necrosis also. Madam, please, what's your opinion? Cellulitis, does it include the component of necrosis or gangrene also?
Not really.
Yeah. So, what are the important clinical features, Dr. Fahad?
Start. The patient will have fever, mild grade fever, not like neck rash, but skin will be tender, will be red in color.
Yeah. So fever, tenderness, edema. These are the classical clinical signs by which we diagnose. So if we define cellulitis as a non-necrotizing soft tissue spreading infection, it involves the deep dermis and the subcutaneous tissue. But mind you, it doesn't goes up to the fascia or below the fascia into the muscle and the deeper structures. It is mostly confined to the distal extremities, but no part of the body is spared. It can be any form. So a milder form would be just like a pustule or a erysipelas, but a greater form will be something like the necrotizing fasciitis or the NSTI. The causative organism usually is the gas or the group A beta-immunotacus streptococcus or Staph aureus, including the MRSA. These are the commonest organisms. And the clinical criteria involves, if two things out of the four clinical criteria, that means warmth, erythema, edema or tenderness is present, it is sufficient to make a diagnosis of cellulitis. Mind you, there is no purulent or pus formation or an abscess formation in cellulitis. So this is the typical clinical picture what we get, lower extremity. So there is a edema, erythema, induration is there, patient must be running fever, and pain is of course there. So how to evaluate? Dr. Fahad, if you get a patient of cellulitis, how will you progress to evaluate the patient clinically as well as what other things you would like?
The diagnosis is clinical.
Yeah, that's true. Mainly clinical. Any investigations or something else you want to do in cellulitis?
Apart from TLC and DLC, CRP can be done.
Okay. Dr. Newmy, looking into the clinical aspect of all these 3-4 criteria, anything else you would like to evaluate in cellulitis? Like the picture what we showed in the previous slide, this one. So clinically these things are evident. Any other evaluation would you like to do?
First of all, I will stress upon the clinical history and the examination, how it starts and what is the time period.
Okay.
And after that, I will advise some laboratory investigation.
Okay. Before that, any complications or adversities with cellulitis per se can cause. So it could be like it is in a compartment. It can lead to a compartment syndrome. It can be lead to venous thrombosis also. So you have to look for the pulsations and compartment syndrome features like that. So locally, evaluation of the clinical signs, distal pulsations, and monitoring of the compartment syndrome is an important feature. There are certain red flag signs. So when cellulitis is worsening, how would you know Whenever there is a development of a vesicle bulla or the presence of a dermal edema or lymphadenopathy is there, that means your cellulitis is now progressing. It's now progressing. Okay? So you have to be aware of these clinical conditions. And then cellulitis may sometimes form because of the source which is there in the skin only. So what are those high risk conditions which predispose for a person to develop cellulitis? Dr. Nerita.
So diabetes mellitus, very common.
Local skin conditions
Local,
first.
then we have lymphedema.
Yeah.
Then we have venous, long-standing varicosity leading to venous eczema. Those patients also.
So if edema is there in the soft tissue, that predisposes for that is the highest local risk factor for development of the cellulitis. Anything else?
History of trauma.
Trauma. So any breach in the epithelial cover, any trivial trauma or scratch or anything like that. And then of course there are the systemic high risk comorbidities like diabetes and obesity and extremes of age, all these things are there. So whenever there is a breach in the epithelial lining and there is also a condition which predisposes to the development of cellulitis, one falls into this clinical condition. For investigation, of course, biochemical parameters needs to be sent because you need to know what is the biochemical status of the patient, what is the WBC count, how much is the hemoglobin, what is the nutritional status. But as I said, clinically also you should evaluate the lymph for the compartment syndrome and the vessels. So you have to investigate it at least by a Doppler, because sometimes there may be, I will come later, there may be mimickers for cellulitis as well. So like this condition, the patient now is developing a bleb. So this is now a worsening cellulitis. Okay? So what is the treatment that needs to be offered? Means antibiotics. You mean to say antibiotics, okay? So what antibiotic? What antibiotics commonly you use in your practice when you see cellulitis? Yes. Yes, Coamoxiclav is a very good option because we know that it is the gram-positive bacteria, mainly the Staphylococcus, which form the major chunk of the organisms which cause cellulitis. Would you like to admit this patient? Most of these patients need admission or they are treated based on the OPD treatment only. So, majority of the cellulitis, you would say that you would like to admit this patient, or you will prescribe the oral medication along with certain, comorbidities and optimization of the comorbidities and send the patient at home. What is the requirement of the major chunk of cellulitis patients? So before that, I would like to ask in your practice whether you advise a oral antibiotic or a injectable antibiotic to these patients, especially cellulitis, just confining to cellulitis, not complicated cellulitis, not extending to something, an STI like that.
We start with
Oral antibiotics. So oral antibiotics is the usual practice.
Sorry for it. I think apart from that, you can open questions to the
Sure. So I think
we have stalwarts like Dr. Ashok.
I would just like to point out that so many things like fever are important, because if my patient, the one you showed with the first picture, if that kind of a patient presents to us and that patient is febrile, we would definitely like to start with IV first.
So
Don't think of oral, because it is not only the lesion that is important, but the systemic accompaniments are also equally relevant.
yes. So any difference of opinion of the house? So
Professor Ashok, yes. Again, Professor Ashok, there is a macrobiologist and now teacher.
So it's going very excellently. I think one point I would like to make is that the pathogen involved is streptococci. Because if we're talking about only cellulitis,
yeah.
because Streptococcus hemolyticus or beta streptococci has spreading features, while Staph aureus has coagulase. So it normally has a tendency to form pus. If there's collection of pus, then you should suspect staph. If it is spreading, then you should suspect Streptococcus hemolyticus. And Streptococcus hemolyticus is highly sensitive to penicillin. It just smells penicillin and it disappears. So penicillin will be the cheapest and the most effective if you give parenterally. And now, if you are thinking of a Staph aureus, then at the back of your mind, you must know what is the chances of MRSA. Because in India, we don't pay too much attention to MRSA, but MRSA without intervention keeps moving from 30% to 70%. So, a mock flap will have no effect on MRSA. So that is distinct to failure if MRSA is present. So that means that microbiologists must tell you regularly what is the chances of MRSA so you can predict. But otherwise, I think it's going on excellently.
Yeah. So we have also mentioned, sir, the same thing. It was a very excellent point to distinguish clinically which bacteria out of these two are there. And then you select your antibiotics based on that. Dr. Basu, you were telling something.
This is a good point. Sometimes cellulitis can happen locally. A bee sting, it produces cellulitis, right? The problem is, necrotizing fasciitis also present initially as cellulitis, which we don't see because that is the time the patient is at home taking its cellulitis and putting all sorts of ointment. When they come, the black texture which is there, we tend to find it. But early cases of necrotizing fasciitis also present as cellulitis.
Yeah.
And most of the necrotizing fasciitis has a deep-seated prick which introduce the coagulum in the deeper tissue. And that's an anaerobic environment also.
Yeah.
Produce an anaerobic environment also. So in situation of gout, it is better, for example, not getting crepitus or gas formation which is there in the deeper tissue. In situation of gout, we can also add, what we will do is anaerobic cover to it.
So very valid point. I think both these points are there. Everything depends upon the clinical presentation as well as the progress of the patient based after you have initiated the treatment. Because initially what may appear as a cellulitis just may have a deep-seated abscess later on or may turn out to flare up into an STI or may involve a systemic inflammatory response syndrome also. But what we are talking about today is majority of the patients of the cellulitis, they have these two bacteria as their most common type, and majority of them may be managed by oral simple antibiotics with a 5 or 7 days course, which usually is our practice also, I think. So surgical intervention, requirement of a surgical intervention, madam, what's your opinion? Like once we are having a cellulitis, when to do a surgery and what type of surgery is usually needed?
Well, I think most of them respond to antibiotic therapy.
Yeah.
But if you feel that there is increasing, you're worsening like you said, and you find there is, or you suspect something like a compartment syndrome, then you might have to relieve.
Yes. So that was the point, that whenever you see a red flag sign or the features of systemic inflammatory response syndrome, then you know that now this is the point when your intervention needs to be aggravated and a surgical intervention is needed. Dr. Newman, what would you do for a lower limb cellulitis who is now worsening or developing a compartment syndrome or the pain is now progressively increasing? So what intervention in which form?
So in these scenarios, I will go ahead with a tracheotomy first and release the pressure, and I will regulate the tissue, how is it, whether it is bleeding or not,
Okay.
whether the tissue is healthy or not, and I will try to do some finger prop test to whether to just clinical confirm whether it is converting into the necrotizing fasciitis
Yes.
or not.
So this is very important, that once you are going for a surgical intervention, see, incision and drainage is there when there is a pus collection. When there is only inflammation and the edema is there, Then also there is a situation which would lead to a compartment syndrome, if not worsening into a necrosis or into a pus formation. So what you do is that you release by giving an incision, longitudinal incision in the extremities and the incision along the Langer lines in the other parts of the body. You dissect up to the subcutaneous tissue first, because if it is localized to cellulitis, it is going to be in the level of the dermis or the subcutaneous tissue. Then you observe into the deep fascia. If the fascia is all right, you don't incise at that time. Give some time and observe, because once you incise the fascia, the muscles they pop out. It's very difficult for that fascia to. This wound won't heal easily. So always going and opening the deep fascia should not be the first approach. It has to be a step-by-step approach.
So, just
Yeah.
why you are going for fasciotomy at this level?
Not fasciotomy, sir. That was my point.
No, what I want to say,
Yeah.
if there is redness,
If
there
it
is
is-
no blister formation.
No, I initially said only when the red flag signs are there or the patient's symptoms they are increasing in spite of your treatment.
So there are certain parameters before putting knife.
Yeah.
Like go for the distal pulses, go for pulse ox, go for the intra-compartment pressure, then you go for fasciotomy. Best would have been this limb elevation, do it for say 12 hours to 24 hours. See, if it is wrinkles are coming, when the device subsiding, no need for fasciotomy.
Exactly, sir. The same point well taken. It's the same what we are also talking about. So usually a 5 days course of antibiotic, you have to look about the methicillin sensitive or resistant incidence in your own hospital setting. Amoxiclav is a good option. Other thing is like a cephalexin or a clindamycin. For if you suspect that MRSA could be there, then you can start with the oral trimethoprim, sulfamethoxazole, doxycycline, clindamycin or a linezolid. Newer drugs are available, but as such, majority of the patients will be managed with oral antibiotics without a need for admission, and IV therapy is indicated only once 2 out of the 4 criteria of SIRS are meeting, or mainly when the patient is worsening in terms of the clinical presentation or the investigations. So Dr. Narita, now can you just elaborate something which is not exactly a cellulitis but mimics like a cellulitis? Because in dermatology, I think you may be seeing more spectrum rather than we as a surgeon are seeing.
Sir, there's a condition called lipodermatosclerosis, which happens when there is long-standing venous, varicose veins and venous edema. Finally, there is sclerosis. So these patients often have episodes of cellulitic-like lesions where there is erythema, tenderness, but it doesn't go to the level of cellulitis, It keeps on recurring. Then there are other causes like, cases of cutaneous small vessel vasculitis.
Yeah.
When it's very, prolific, usually they present as very minimal palpable purpuras. When it is very prolific, it might, look like cellulitis. Then there are drug reactions which can occur, bullous fixed drug eruptions that can occur. Then there is a condition called erythromelalgia. It's a genetic condition where there are recurrent episodes of erythema warmth. And there are conditions like, others like, there's a eosinophilic fasciitis is also the cellulitis. So where, it mimics cellulitis so much, but there's eosinophilic infiltrate when you do a biopsy. Eosinophilic cellulitis, those are mimickers.
Yeah, I was just expecting a bang on from a dermatologist for all these conditions, because majority of these conditions we usually don't, encounter or we don't diagnose. So simple formation of a pustule or a, folliculitis, that may also be a presentation. Sometimes there are conditions like herpetic infection that may mimic, but it's clinically you can differentiate with the treatment is entirely different. There may be a contact dermatitis also when there is a, inflammation of the skin. Stasis dermatitis, what you were talking about, the lipodermatosclerosis, gout may present with a local inflammation. The pathology is totally different, management is totally different. Pyoderma gangrenosum, you had a very nice talk yesterday. Deep venous thrombosis and superficial thrombophlebitis. These are the very common conditions which mimic exactly as a cellulitis. Giving antibiotic, may or may not be necessary, but addressing the primary cause and treating specifically is the treatment what is the need in such conditions. So one has to be aware about the clinical mimickers of the cellulitis. Now we are coming to the NSTI. So necrotizing fasciitis, which is the part 2 of this panel discussion. Its better term is the necrotizing soft tissue infection. So first, Dr. Fahad, how do you differentiate between a cellulitis and a necrotizing fasciitis or a NSTI?
Usually the presentation when we say the poop and poem. Poem is when there is pain out of proportion.
Yeah.
Poem is when the pain is extending beyond the margins.
Very nice. Yeah.
With the presence of bulla and other features are also there.
Okay. Dr. Numi, anything to add upon?
And then maybe at scriptus.
Crepitus is there. Yeah. Gas forming bacteria whenever they are there. Okay. So it's very clear that it is totally different condition, although it is an aggravated form of cellulitis, but both these are independent conditions. Are there different types of NSTIs? Any idea about this? Dr. Numi, if you can tell.
Basically, sir, maybe of two types. Type 1 maybe due to body microbial and
Okay.
microbial.
Yeah. So one thing important about the NSTI when it goes to NSTI or when the infection is of the caliber that can turn out into NSTI is that it is usually a polymicrobial infection. One. And second thing is that usually anaerobes they also come into the picture whenever the NSTIs they are coming. What are the typical sites, madam, if you can tell? Typical sites of NSTI or Dr. Numi? Dr. Numi, what do you
One
find?
is lower extremities
Yeah.
and the perineum also.
Yeah. So
And,
everybody
abdominal.
everybody who is clinically practicing might also have seen none of the site in the whole body is spared of necrotizing soft tissue infection. I mean, it can happen in the head and neck area also, which is quite vascular. It can happen into the upper extremities, chest, anti-abdominal wall, perineum, lower extremities. But largely majority of these patients will be of the lower extremities, followed by perineum and abdomen, and the rest of the body is quite rare. So what I was talking about, the types of NSTI also depends upon which site it is getting involved and what bacteriology is there. So common bacteria is what we can have. I think Madam can tell for NSTI what usual organisms they are.
So as Professor Ashwathan has mentioned, it is NSTI even we think for streptococci at the very beginning. But what skips the mind is Staphylococcus aureus can also have this necrotizing presentation. It is mostly gram-positive organisms which have this necrotizing problem. Otherwise, gram-negatives are not involved, though involved in soft tissue, but not in the necrotizing effect in most of the English.
What about the anaerobes?
In coming to anaerobes, actually the diagnosis for anaerobes becomes late. And it is that time when intervention towards in aggressive way to a deep extent is required. But anaerobes in most of the cases goes undiagnosed.
Yeah.
Though they have definitely a role, I will place them maybe after streptococci in causing necrotizing soft tissue infections.
Sir, any opinion about microbes?
I don't have any practical experience with culturing any one of them, but from what I have understood is that anaerobes, whenever there is any linkage to the peritoneum or to the gut, there's chances that you would have anaerobes coming into that. Or could be nowadays, I guess we are also thinking about bacteria which are present in the gut because of this biases sometimes coming and populating in area and then worsening the situation because Staph aureus and Streptococcus are facultative anaerobes. That means they will grow better. They can grow in the presence of oxygen, but also in the absence of oxygen. So, Clostridia is something which is normally involved when there is injury. Then Clostridia tetani and Clostridia weltschaft is. But bacteroides during peacetime, it is bacteroides which is normally involved in necrotizing or bursting the condition. But I don't have any practical experience with this. I think if you make a smear and the bacteria, you see gram-negative bacteria and it doesn't grow, then you know that you are dealing with that.
Yes. Professor Percy, something, yeah. Anaerobic culture. Yeah.
There are not many anaerobic. In fact, she has, we had this thing. Lot of atypical pathogens come, especially the perineum, perianal area, many fasciitis which are associated. And since we are unable to pick those up, we think that they are not there. But it's a perfect combination, aerobic and anaerobic. One implies oxygen, the other thrives that way. Tissue oxygen tension goes down, so they immediately start playing in that area. So it is there, it is not that we cannot deny.
Yes. I think what practical problem we are facing, because we are not getting the anaerobic culture, so we are not having any view that what is there. But what has been suggested in the literature is something interesting. So first, I'll come to all these points one by one. Defining an NSTI is a life-threatening invasive soft tissue infection having a necrosis component first, and it involves any or all the layers of the soft tissue. That means it can go up to the fascia, below the fascia, up to the bone, anywhere. So it's the depth which is now increasing. What is the pathophysiology will come later on. So we can have a picture like this in the lower limb, a Fournier's gangrene in the scrotum, or a Melny's gangrene in the anti-abdominal wall. So basically no site is there but which is spared, but necrosis and any thickness of the skin involvement which it clearly demarcates it from, apart from the worsening clinical condition, from what was cellulitis which was initially discussed. So aggression and progression, these are the two hallmarks of NSTI. It spreads through the facial layer, that is why it was termed as a necrotizing fasciitis. As I said, extremities, abdomen and perineum are the common areas. Sometimes it could be because of a secondary cause, or most of the time it's primary. Diagnosis is based clinically. Okay? So before we talk about the diagnosis and initiation of treatment, I would like to have an opinion of the panel. Dr. Fahad, once you see a necrotizing fasciitis, what is your approach for making a diagnosis?
It is clinical diagnosis.
Yeah.
And we have to see whether the patient is having severe systemic features. We should urgently go for the surgical intervention.
Yeah.
Otherwise, if we have time, then we can go for lab markers and imaging. And
Yes.
focus is one thing that can be done most likely. Point of focus ultrasound.
So one thing is there that it carries a very high mortality rate. So studies have also quoted the mortality up to the tune of 70 to 80% in the series of the patients which has been reported. And this underscores the need of a timely diagnosis and intervention, which is very important. Of course, you have to look and you have to send all the parameters, but you don't need to wait for it to be proven through the laboratory or through the radiological investigations that the patient is having an NSTA, and then you would like to do something what is needed to the patient. So what classification what I was talking about is that there are four types of NSTA. Type 1 is the most common. It's a polymicrobial infection. What literature has suggested is that there has to be at least one or more than one anaerobe, along with the strepto and staph which is there, of course. Type 2 is a monomicrobial. So what sir was telling and madam was telling, so it has got strepto and staph, and they have an aggressive form, but they are limited to a lesser form, but because of the necrosis it spreads. Type 3 is usually what sir was telling, sometimes you get Clostridium and Vibrio species. They are very rare. They are rare. So most common, less common, rare, and the fourth is because of the fungal. Sometimes fungal infection may also lead to NSTA. They are very, very rare conditions. So what was the pathophysiology? Anyone from the panel can tell about? What's usually the pathophysiology in NSTA? How the same bacteria which is after the abrasion causing just a cellulitis responding to a oral treatment, how does this anaerobes come into picture when there is a abrasion of the skin? Any opinion about from the panel? Although it's something which is unrelated to our clinical practice most of the time. So, if you see the pathophysiology, it is basically of two types. One, when there is a defined portal of entry. Just like cellulitis, there is an abrasion, there is an entry of the bacteria, the blood vessels are there. Now there is a platelet leukocyte aggregate which is forming, which is now coagulating the smaller vessels, the venules and the arteries, and leading to gangrene, and later on there is a formation of a bulla or ecchymosis, and then the gangrene happens. But many a times what we see in the patient that started spontaneously. They don't give any history, you don't find that there is any trauma or any abrasion. So there is another physiology when there is a deep-seated trauma. These patients, they are a predisposed population. So what happens is, when there is a deep-seated trauma, there is an influx of leukocyte and activation of a myogenic progenitor cells which have a pimentin on their surface. And there are transient bacteremias happening then and there in every patient. And then because of this pimentin, these bacteria, they come and start infection, and then there is an aggravation. So both these pathophysiologies has been described in the formation of a NSTA. So we have already discussed that clinical judgment is of paramount importance more than laboratory investigation. That doesn't mean that you don't need to send them, you need to send them. There is a triad of swelling, pain which is much more out of proportion to the physical findings and beyond the involvement of the skin, as what Dr. Fahad has very rightly said, in the presence of erythema. So if these three clinical features are there, then apart from local warm sclerosis, dishwater type of discharge is there, dirty water-like discharge. And very important clinical finding is when there is an ulcer, or if you are doing an incision drainage, you probe it with your finger and you don't find the tissue resistance what you normally expect. That means the underlying tissue is necrotic. So it gives you a clinical picture. Now this is a NSTA and you need to do something. Okay? Patients who present late, they often present in a very severe form and may present in a septic shock also. Investigations, I said, they are there, and there are various scores for NSTA. Any idea about the scores? Usually we don't practice in our clinical thing. The scores basically they are more of a prognosticating type of scores. But one score what we have is the laboratory risk indicator for necrotizing fasciitis. It has been very widely studied. It includes the CRP as what Dr. Fahad was telling. Normally we send WBC, hemoglobin, electrolytes, creatinine, glucose, but we add on a CRP, and based on the scoring system, we can score it either as a less than 6, which carries a very low risk. All these risks are for the risk of the mortality, or a risk of 6 to 7, which is borderline, and a risk of more than 8. So basically, they are the prognostic scores rather than a diagnostic scores. So there was a meta-analysis which was published in 2019, and they established the various clinical parameters like the presence of the fever, hemorrhagic bullae, hypotension, investigatory finding, and this LR-INEC score. But if you see, none of the scores, either they are highly sensitive or highly specific. Even if you take a LRI-NEC score of more than 8, the sensitivity is 40.8, but it has a high specificity. So basically, they are much of a prognostic importance than having a diagnostic value. Now coming on the intervention, Dr. Newmy, how will you, once you have a high suspicion, because this patient is a sick looking or you see a necrotic patch, how will you intervene and when will you intervene? What will be your intervention in that?
First antibiotic coverage has to be given, and if you see any necrotic or gangrenous tissue, then you have to do the aggressive surgical debridement.
Yeah.
And serial surgical debridement, followed by the vein gradation and dressing that will be continued. And the adjunct therapy you can give is you can give a regulated negative pressure wound therapy also. But
So coming into the intervention in terms of debridement or removing the necrotic slough or the black tissue, I would like to ask you in what setting would you like to do it? Suppose the patient has landed up in the emergency OPD. You see, your resident has informed you, say that okay, do a debridement. So which setting? In the OPD, that is bedside, OT, general anesthesia, regional local anesthesia, or what additional setup you would like to have?
First we have to examine the patient. If the patient is critically ill, then at that moment we don't have to waste the time and immediately we can do at the bedside.
So what do you think should be within what time the intervention has to be done, the surgical intervention?
So we have to start immediately. If you see any necrotic tissue or gangrenous tissue have developed and we see that these water are false smelling, then we have to start immediately. We cannot wait.
So in NSTI it is said that time is life. Just like ischemia, anywhere there is a ischemia or there is a thrombus, you have time. Usually the time what is taught is a 6-hour time. Here also the time had been studied in various studies from 24 hours, 12 hours to 6 hours, and it has been now established beyond doubt that the patients who have been intervened within 6 hours, they have a better outcome rather than those patients in which there is a time gap of more than 6 hours. Usually these patients, they are quite sick, very sick. They may not respond the way usually the emergency patients are. So you have to have a critical care support ideally ready for such patients. Never try to do any necrosectomy, any debridement, anything bedside. It has to be done in a OT, in a proper anesthesia setup. And there are multiple people who are involved in the management of a NSTA. Dr. Fahad, you are a plastic surgeon, of course. You don't see the patient immediately, you are basically needed whenever the acute inflammatory process is over. But what do you think, what are the various components in which, or who are the various people who should come together whenever managing a cellulitis, the NSTA patients?
Apart from the
Anesthetist, intensivist, yeah.
plastic surgeon, nurses,
Nutritionist, very much. Yeah. So it's a multidisciplinary approach. The patient is sick, the patient requires a very good medical as well as a surgical care. Normally it is thought that it is the domain of a general surgeon or a surgeon, debridement, but surgeons, they fail in providing that acute critical care in their own ward, or they may not be knowing the current, the updates about the antibiotic therapy and all. So internist should be involved in making a decision about the antibiotics. Microbiologist should tell about what is the flora running into your hospital. Basically, these are polymicrobial infection, and you have to, first thing is to start with a source control and a appropriate antibiotic. Various team persons, because this intervention is not a single time intervention. You have to debride once, you do a maximum debridement, but then you should be ready to have a second look and a second look debridement the very next day, and this may be repeated for multiple times. Once you debride, you need to have a good nursing care and a good dresser to take care about the wound. You have to have a certain, back therapy and all these things are there, will come later on. Then you have to have a good physiotherapist so that the patient is mobilized, the patient, is not gets fallen into the trap of hospital acquired infections and complications. So there was another systematic review and meta-analysis about the timing. It was a total of 109 studies and more than 6,000 NSTI patients were pooled. And it was clearly demonstrated that surgical treatment within 6 hours resulted in a 19% mortality rate compared to 32% when the surgical treatment was delayed more than 6 hours. So it has been found that the mortality has not changed over a period of time. But the important thing is the intervention. Sir, you want to say something?
Yeah, I have a question here.
Yeah.
Because most of the studies which they publish on NSTI, is our business actually starts from admission.
Yeah.
But there is a lag hour which happens before the pre-hospital.
Pre-hospital period. Yeah.
So that's a significant aspect. And most of the studies don't take into account of that part.
That we can say is our setup problem, because there what happens whenever there is a problem, they have an immediate access to healthcare, community nurse or ambulance, and the patient is immediately shifted. But we see the patients, they first get themselves treated at home, then they visit to a nearby hospital and then they reach. So these are the just things about the evidence. But as Dr. Numi has said, as soon as possible and after certain optimization. That means you have to start a IV fluid, give a dose of antibiotic, arrange the ICU and get a proper setup. This should be the only time lag that should happen.
Dr. Vivek, what I feel, this is the article again from outside.
that is the limitation.
In our scenario, the mortality rate is quite high.
They have also reported a mortality rate of up to 70% in various studies.
So, because in our setup, the patients come in a very, very late.
Very late. Most of these patients, what they present, they are already in sepsis and septic shock.
Despite of all the, patient is in irreversible septicemia. So despite of all the intervention, debridement, antibiotics, whatever you are doing, patients not.
Fungal infections, it is more than 90%. Basic fungal infection.
Yeah. So antibiotic therapy, which remains the mainstay, it is impossible to exclude with certainty which bacteria, how many bacteria are there. But we have to start with a broad spectrum antibiotic. And here comes the role of the antibiogram, as Madam was telling yesterday, and we had a talk with Dr. Basu also. You need to know what is the local, your hospital antibiotic sensitivity to all these, covering broad spectrum antibiotics. You have to also take care of the MRSA. Then definitely you have to send the cultures, the way it has been described yesterday, various cultures, repeated cultures need to be sent, and then most of the time you change the antibiotic based on the culture. So usually what in your practice is the duration in which the antibiotics usually are advised? Dr. Numi, any idea about how much duration these NSTI patients they require antibiotics? Then will come what literature is saying, and that too Western literature.
First we have to give empirical treatment by the time.
No, the duration, the total duration of antibiotics, 10 days, 2 weeks, 3 weeks, 6 weeks.
We have to give approximately 10 to 14 days.
So it has been what has been documented in the literature is that almost 4 to 6 weeks of antibiotics are required for these NSTI patients. And this data is not our Indian patients, they are all Western data. The only thing is that we start with antibiotics, there is a big wound. Even the wound is granulating, you are not arranging for the closure or grafting or whatever of that wound is there, that also you require antibiotic. So the Western literature
that
says.
is the most important aspect. Because as a surgeon, we generally give for 10 to 15 days and we stop it. So antibiotic has to be continued for longer time, minimum of 3 to 4 weeks. You can keep on changing depending upon the culture.
So we start with the broad spectrum antibiotics, usually the carbapenems or piperacillin tazobactam, one of them along with the vancomycin or clindamycins because of the suspicion of MRSA. Then based on the culture, you shift into different types, what antibiotic is usually required or needed, and then there are certain adjuvant treatments. Okay, so as Dr. Newman said, NPWT, we have very several good lectures about the NPWT. So just quickly, Dr. Newman, what are the advantage of you find in your practice of using NPWT, especially in necrotizing fasciitis patient post-debridement?
First of all, it reduces edema, tissue edema, it reduces the rectal loss and aggregation, and it increases the granulation tissue function.
So you basically approximate the edges, so the wound closure it facilitates, it takes out the exudates, reduces the bacterial burden, increases the granulation tissue formation. But any risk of using NPWT in NSTI patients?
In case of culture, in case of anaerobic infection.
Yeah, very nice. If the anaerobic bacteria is there, then probably putting a NPWT may worsen. This is one thing, because this is a condition where type 1, they have anaerobic bacteria there. And the second thing is, because the wound is very wide, vessels are exposed, granulation is there may be a risk of bleeding. And sometimes the bleeding happens and you need to, stop or decrease the pressure of this NPWT certain repeated debridement. You have to decide up to what point your wound is now showing an improvement, and that is the time when you switch from IV antibiotics to oral antibiotics. In usual practice, if comorbidities and everything is getting controlled and the patient is, there is a patient factor also. Usually it takes 10 to 14 days in which your antibiotics, are showing good response. So between, say, a second week is the time when you should apply a NPWT. Hyperbaric oxygen therapy, any experience? Any experience from the experts in the audience? Yeah, please.
Yeah, we do a lot of hyperbaric in these patients. The time is when the patients are stabilized and you have done adequate debridement. The difference between NPWT and hyperbaric is, if the wound bed is not prepared, that is, like you have still necrotic tissue or plaque and everything, the NPWT is not going to decrease the bioburden. There have been debated articles in the literature that shows that some say yes, some says no, even RCTs have been done, but it doesn't much help. So whenever the tissue lacks that amount of the oxygen supply, hyperbaric plays a very good role. So these patients can be treated by hyperbaric after they are stabilized, of course, and if there is no contraindication as far as the hyperbaric treatment is concerned. So NPWT does a very good job in bringing up, say, about a week's treatment, every day a week's treatment, bringing up these patients to improve the wound condition so that you can apply the NPWT.
Sir, any evidence-based support for hyperbaric oxygen therapy?
No, hyperbaric oxygen therapy will not heal the tissue. The tissue is going to heal on its own.
Yeah.
The tissue which is suffering from that anoxic part or the hypoxic part, that part is going to take care by the hyperbaric oxygen therapy.
So the wound healing trajectory, what in natural course is going to be very slow, it hastens that. Both
Yes.
the NPWT and the hyperbaric oxygen.
Yeah, they have two differential approaches.
Yeah.
You can't combine them together.
No,
It's
no,
not going to
no,
act.
no, no, it is not going to add. They are two different independent entities.
Systemic or local?
Systemic. Local hyperbaric, please don't do.
Something about IVIG, any experience? So IVIG is probably, we also don't have any experience, but there is a word of IVIG used in literature. So severe conditions, septic shock patients, they are the candidates where IVIG is used. But all these three, they are not established, they are not established by evidence-based support for their use in NSTI, although all these things are helpful in their own way, limited, tailored treatment should be offered. So Dr. Fahad, we come to the almost the end. Once this acute thing is over, how do you cover? How do you cover or reconstruct?
Depending on the size of the wound.
Yeah.
It depends. Then we can go for the local flap. interior garden, free flap.
Yes. So one thing is very important, that the closure needs to be done delayed most of the time in NSTI. We have a full array of options from SSG, FTG to flaps, depending upon the region and the size of the defect, depth of the defect, and what is the location. Like in a perineum, even if it's a very good granulation, you would like to go for a flap because it's an infective area. So you have to look for, you have to have a good reconstructive plastic surgeon once you are treating a patient of NSTA. That is why it is called that it's a team approach. Various people have their own inputs at various, time of the disease progression. And of course, reconstruction and then rehabilitation, psychiatric involvement, the help from the psychiatrist, because these patients are too sick, they require very prolonged hospitalization. So different components they are needed, and everybody has a role in the treatment of NSTA. So I think with this we come to the conclusion of this panel discussion. Just to conclude, cellulitis is a superficial spreading infection commonly caused by Staph or strepto, clinically diagnosed most of the times. Antimicrobial therapy, mostly in the oral form, is the treatment of choice. Rarely they require a surgical intervention. In contrast to NSTI, which is a very aggressive and progressive type of form of cellulitis, where surgical intervention is the mainstay of treatment. And you have to start a broad spectrum antibiotic covering everything, looking into the flora of your setting in which you are working. And there are certain adjuvant therapies which they help, and reconstruction remains a very important part whenever you are managing an NSTA. So any other?
Sir, if you allow me
Yeah, please,
to add
please,
a point.
please.
Regarding sending samples for culture, for cellulitis, it's important to send a tissue sample, a punch biopsy sample, and if resources are available, if the patient is in a immunocompromised state or the patient is comorbid with a lot of factors in the ICU, and if resources are available, I think a multiplex PCR helps a lot.
So any other questions? If there are none, then I thank my panelists. I think we had a fruitful discussion. Yeah, please. No, we are talking about NSTAs.
In NSTA,
Because in cellulitis, do you think you need to give hyperbaric?
as
most of the time.
IWGP guidelines 2025, hyperbaric oxygen therapy is no more an adjuvant therapy. It is the first line of therapy in most of the wound infections.
Okay.
This is the latest guidelines.
Okay.
So what they are saying is, first you give hyperbaric, reduce the inflammation edema, then you do your procedures, you will have a limited wound recovery.
Okay, I am not aware about this.
Yeah.
Thank you. So I think we end with this. I thank all my panelists. Thank you so much.